Thank you, Dr. Abhi Sharma and Sahani sir. Good evening, good afternoon, and good morning. This is the 1480th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. SAPTARSHI Chaudhary from Calcutta. Let us begin the session with 1 minute silent prayer. Thank you all. As you all know, the International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi, but it begins from 7:30 to 8:30, and from 8:30 to 9:30, the international session in English, and 9:30 to 10:30, a local language session in Malayalam. And we are uploading almost every videos on the very next day itself at your YouTube channel. So those who miss the first part or the second part of the session may visit the YouTube IFBH Homeopathy and can watch again and again the same. You can subscribe the same without any penny. That's the beauty of International Forum for Promoting Homeopathy. We welcome all to the session. Today, as you know, that today our guest is Dr. SAPTARSHI Chaudhary MD, Homeopathy. Sir is the professor and head of the Department of Practice of Medicine and visiting physician at Mahesh Bhattacharya Homeopathic Medical College and Hospital, West Bengal. And he has more than 20 years of clinical experience, has done major works in college during the curriculum time, and he's a question paper set. And as you know, that being a professor, he has a lot of responsibility in college, and he's doing all this work in an excellent way. And he has published some 5 to 6 books. One Chowdhury's deep vein thrombosis cured by homeopathy, a case report of Ayurveda merger medicine, then homeopathic medicine used as prophylactics in Calcutta during the COVID-19, then homeopathic management of pain and stiffness of arthritis, knee joint, and clinical data analysis. Like that, so many books were written, and he has taken national as well as international sessions for general homeopathic practitioners also. And today, Doctor will be discussing about the scope of treatment of DVT to, as you know, DVT is deep vein thrombosis to a homeopath, an evidence-based approach. This is what the need of the hour, because we have to upload these things to the public so that public are not aware whether homeopathic doctors can do all these wonders. Yes, homeopathy has a solution for all this. So we are very happy to welcome you to the session, and Dr. SAPTARSHI Chaudhary, sir. Welcome, sir. You can.
Yeah, I think now it's okay.
Yes.
With a small prayer, we can start. Om Sahanao Avatu Sahanao Vunaktu Sah Viryam Karva Vahe Tejvasvinao Adhihitamastu Ma Vidbishavahe. Om Shanti Shanti Shanti. So my today's topic is scope of treatment of deep vein thrombosis to a homeopath, an evidence-based approach. Now, thing is that DVT, what is DVT? First, we have to discuss about this thing and why it is important. It's just a clinical condition which is characterized by the formation of blood clot, in a very layman's term, we can say, in deep veins. And usually it actually affects lower limbs, most of the cases, in many of the cases, apart from the, the upper limb veins or of the arms or pelvis, but commonly it actually affects the lower limb veins. And of them, most commonly, the iliac veins, then femoral vein, and obviously popliteal vein, and the anterior and posterior tibial veins. So these are the veins which usually gets affected because of the deep vein thrombosis. And it is important. Why it is important? Because it actually produces the high risk of pulmonary thromboembolism, and which is again a very serious clinical complications of DVT, and which may lead to death in any patient, and post-thrombotic phenomena, which is again another important factor, like damaging the valves of the vein that produces the varicosity or varicose vein, and it is related its related complications, which is actually ultimately produces the limitations of normal life and constant economical burden on patient. And in our country, as we all know, we really, because of our population structure and obviously and other factors, the out of pocket expenditure is much more while a person is going for his or her medical treatment. So again, and the people, those who used to come to us, mostly the homeopaths, we get, wide variety of patients, from the very filthily rich patient and from the very poor patients also. And perhaps the poor patients are more, mostly, what I can say as from my experience in my hospitals, or so we have a government hospital, we get patient over there. The large amount of patient pool is coming from the from that economical stature, those who cannot afford much of their money. So there, if we can give a better treatment choice for such cases, obviously we can save the patient's life and obviously economical burden on him or her. Now, next is, uh, these are the DVT fact sheet. Let me come to this thing. As most of the cases of DVT initially appear silent. This is a very, very important point. And it poses an immense diagnostic challenge for early detection of treatment. And because of this thing, many a time it so happens that patient may not come to a doctor, may not visit a doctor while he or she doesn't know that they are suffering from DVT, and which obviously puts a threat to develop pulmonary thromboembolism. Always that I say. And this thing, I'll show you one of my cases in this discussion where the person actually did not recognize that he was suffering from a deep vein thrombosis, and later on, while he actually contacted us, that time with some test and some parameters, we actually found that that particular person was perhaps suffering from DVT. Now, more people suffer from DVT annually than heart attack or stroke. While we are saying that this scenario, I mean, this is the year, or perhaps this is the decade, while the heart attack patients, those who are coming to us with this thing, the coronary artery disease, and obviously equally the diabetes mellitus, these things are obviously going high and high, and perhaps the India will be the capital of this kind of coronary artery disease or diabetes mellitus. And we are saying that thing, but silently we are just, we have to remember this thing, that people, those who are suffering from DVT, annual number of those patients are much more than those patients, those who are suffering from heart attack or cerebrovascular accident or stroke. Now, in elderly population, more than 60 years of age group, DVT is associated with, 21% of 1-year mortality rate. And with the pulmonary thromboembolism, which is again very common complications of DVT, which is associated with 39% of 1-year mortality rate. Now, pulmonary thromboembolism and is a leading cause of maternal death. I am saying about this thing, though I am talking about DVT, but since PE is a very common complications of DVT, that's why I have put this particular point over here. Is pulmonary thromboembolism is the leading cause of maternal death associated with the childbirth, and a woman's risk of developing DVT is 6 times greater when she is pregnant. So this is once again a very important point that we have to remember. A woman's risk is developing woman's risk is 6 times higher for developing DVT while the woman is pregnant. And as we know, previously, the first childbirth and obviously the pregnancy used to come in a female patient quite early in their life. But because of the changed, socioeconomical structure, and obviously since more and more women are right now going away from their home for doing, obviously, for their job and studies. And obviously it actually happens that the first pregnancy usually comes now in around 30 or 30 plus. So in them also, this kind of thing actually even increases. And we have to remember one thing, that there's a small mnemonic, that is FAT-S. That means this fat embolism, then air embolism. While we are thinking about this pulmonary embolism, the common factors are like fat embolism, air embolism, then thrombus, which is basically the DVT, then amniotic fluid is also there, and septic embolism is very less. But the DVT is one factor which may cause this pulmonary thromboembolism. Now, it needs to be remembered that non-surgical medical patients are at equal or higher risk of developing venous thromboembolism when compared with the surgical patient. We have a common notion, or we have a common information, that the people, those who are going for the surgical procedure where they have to lie in the bed for a quite long time, and basically non-ambulatory patients, those after surgery, they have a higher risk of developing DVT. Yes, that is true, but it is also equally true. It has been found in a study, which is the Birmingham Heart study. It has been found that the non-surgical medical patients are at equal, and if not more, or sometimes even more, or higher risk of developing VTE than a surgical patient. But in India, among the hospitalized patients, those who are going for treatment in a hospital, or those who are going for this IPD treatment, 45% medical and 61% surgical shows a risk of developing of VTE. And among the people who have had DVT, one half will have a long-term complications like post-thrombotic syndrome, such as swelling, obviously pain, discoloration, and scaling in the affected limb. And one third, about 33% of people with deep vein thrombosis or pulmonary thromboembolism will have a recurrence within 10 years of time. This point is again that we have to remember. That doesn't mean while we are treating a patient, or once we have treated a patient with VTE, that means we have done our job. It's not like that. We have to, we have to instruct those patients, those who have taken for treatment for DVT, that it may recur in their lifetime within another 10 years. So that's why we have to closely monitor those cases. And obviously, since in homeopathy we have scope where we can give medicine which may prevent this recurrence. So that is one benefit of our treatment that I'll also show in one of my case. Now, one thing that this particular from the surgical cases, this thing I'll ask you to just look into that thing. Since nowadays this knee replacement surgery is increasing, if we see this knee replacement surgery, previously we don't get or people could not afford, number one, and obviously the availability was not also there as much we get nowadays. So people they used to suffer their knee joint problem and etc. They used to come for treatment with and along with that ancillary measures like yoga and exercise they used to do. But now, since people has increased their solvency and obviously there is availability, so there is knee replacement surgery is also increasing. And the people, those who are going for this knee replacement surgery, and they have a very high risk of development of DVT following the surgery. So that is one thing. And people, those who are, since the malignancy cases are also increasing, so the people, those who are going for this kind of, malignant diseases, they also have a very high, rate or high incidence or high chances of developing of venous deep vein thrombosis. So these 2 points actually I wanted to share with you. And one more thing, it needs to be remembered that non-surgical medical patients are at equal. Okay, I think I have completed this thing, and this is the now important risk factor. These are the risk factor. Let us look into this thing. There is a triad that we say it's a Varco's triad of thrombus formation, and which is actually composed of 3 things. One is stasis, that means venous stasis. Since we know the stasis actually gives a more chance, the platelet, they may, interact with the capillary endothelium, and obviously they may form this, the clot formation is actually, risk of clot formation actually increases because of the prolonged stasis over there. And along with that, the vessel wall injury. So vessel wall injury may be a direct injury, or maybe because of any other disease conditions where there are a whole lot of cytokines, those who may actually cause a capillary endothelial damage. But in surgical procedures, like where there is, the central, the venous catheterization, sometimes it has been done in patient. And those who have this kind of history where the central venous catheterization, mostly in the femoral veins, if it had been done, and there is a chance of development of, deep vein thrombosis there also. And two more things that we have to remember, that the nitric oxide and obviously prostacyclin, this nitric oxide and prostacyclin actually gets, downregulated or decreases if there is a vessel wall injury, and that actually promotes more chance of development of this thrombus. And along with that, this hypercoagulability, in case of hypercoagulability, two factors that we have to remember. One is that procoagulant, and another thing is that anticoagulant. Now, increased, or upregulation, rather, we can say the procoagulant and the downregulation of the activities of the anticoagulant, that actually gives a favorable situation of such hypercoagulability. And this coagulant are like situations are like malignant, those who are suffering from malignant diseases that I have just mentioned, and specifically in case of those who are suffering from pancreatic carcinoma or lung carcinoma, like such patients. Or and the more common, we are not getting these malignant cases now very often, but more common, these things that I have uttered in case of female pregnancy is one such situation, which actually helps in this, this increased procoagulant activities. And along with that, one more thing, which is a very common issue, and this particular thing actually invites many more diseases like oral contraceptive pills. They also increase the chance of development of these procoagulant activities. And along with that, there is a, if there is some disease conditions like mutations of genes which are actually synthesizing the factor 5. So if this actually happens, obviously it increases the chance of procoagulant activities in our body. And along with that, the anticoagulant activities like protein C, protein S, and the antithrombin 3. If these are the concentration actually gets down or decreases, there is obviously the anticoagulant activity is also jeopardized. Along with that, some disease conditions like nephrotic syndrome, and in case of female, mostly those who are suffering from lupus disorder like SLE, or female patient, those who are suffering from antiphospholipid antibody syndrome, in whom we are getting the cardiolipin antibody is there. And in case of patients, it's very surprisingly those who are taking this heparin, anti-heparin, drugs, those who are taking, in them sometimes it actually antibodies forms against heparin. And like that thing is like platelet factor 5, it actually forms another antibodies, and they actually hamper the activities of heparin, and in them also the anticoagulant activity gets down regulated. And together with the increased procoagulant activity and with the down regulation of the anticoagulant activity, the hypercoagulable state actually forms. And these three things actually helps in the formation of thrombosis. Now, if we since these are all according to Hahnemannian things, theoretic medicine, obviously, but still we have to know this thing. But as clinician, what we have to, when we are guessing that a patient may form this venous thromboembolism or DVT, the age is a very potent factor. Now, with the age, the risk actually exponentially increases. So age is more than 60 years, we used to say, but sometimes some references are saying that if more than 40 years of age group, patient may develop DVT. Now, long distance travel, usually more than 5 hours of travel. Now, nowadays, air travel is very common, and if a person is traveling through train or car traveling, nowadays, because of the roads, we are traveling a lot in our cars. So those who are traveling for a long distance and those who are traveling by air cross country, rather in these patients, and if they are elderly, there's a very high chance of developing this venous thromboembolism. If they have a varicose vein, if there is obesity, that means the BMI is more than 30 kilogram per meter square, And as I have already mentioned, the comorbid situations, if the patient already had a history of myocardial infarction, if the patient has features of heart failure, nephrotic syndrome, as I have already mentioned, in case of inflammatory bowel disease, and in case of endocrine, different kinds of endocrinal disorder, respiratory disease conditions, polycythemia, again, the stasis actually increases over there. Now, paraplegia, those who are, again, the patient has a high, those who are paraplegic, obviously, they usually do not have the more chance of moving because of their inability. So they have a very high chance of developing this thing. Now, if there is a recent infection, obviously, that creates a wall injury because of the cytokine, increased cytokine level. In case of paroxysmal or nocturnal hemoglobinuria, homocystinemia, again, vitamin B12 deficiency actually favors this homocystinemia. So people, those who are suffering from vitamin B12 deficiency, they have a high chance of development of this. Apart from the, the pernicious anemia, they also have a very high chance of this kind of this thing. Venous thromboembolism. So, and use of HRT, that means hormone replacement therapy, and then estrogen containing contraceptive therapy that I have already mentioned. These are the important factors for venous thromboembolism. Now, other risk factors for venous thromboembolisms are like pregnancies, as I have already mentioned, active cancer or cancer treatment mentioned I have already. Now, dehydration, again, dehydration increases the blood viscosity level, and because of that thing, obviously, DVT, chances of DVT increases. Now, known thrombophilias, I have already mentioned the first degree relative. Oh, again, now there is a history. See the family history. If there is a first degree relative has a history of venous thromboembolism, there also the chance actually increases in case of formation of this deep vein thrombosis. Now, usually we have a the people have a common concept that deep vein thrombosis, oh, it may cause a death because of pulmonary thrombolysis. It's a surgical emergency, and obviously we have go for surgery, or at least to an allopath doctor. We do not have a very big scope. People usually think, and obviously homeopath doctors, we also do not get that kind of confidence. But I'll rather say we have drugs and we can do it. So please try to do that thing. And I'll try to give give you that confidence. Now, how to diagnose this case? And please remember, the most patients have no physical sign altogether, usually at the very beginning. And DVT may occur in a healthy people with no predisposing causes sometimes, or rather, I can say not like that predisposing causes, but sometimes we may skip. If we do not go for a detailed history, we may skip those salient information which may actually act as predisposing cause. A detailed history and a careful inspection of extremities is the only key in case of diagnosis. Since the people, those who are coming to us, most of them are not economically so solvent, especially in case of a government hospital. So we have to rely more on the history. And every time I get a scope to come to your platform, I always say a well-taken history, a well-taken case is half cured, as Dr. Kent has told us. And it is really true. If the diagnosis gets 100 point, history of itself gets 40 out of 100. So important is the history and the careful inspection. We homeopath do not have we really lack this habit of doing the clinical examination. Not all, but most of the homeopath physicians, we rely on the symptomatology. That is very true, but we have to have do that clinical investigation, clinical examination of a patient. Dr. Hanneman used to do that thing. If we go with with his case records, and obviously the records which are available in the Germany, if we have a chance to look at this thing, we can see that how extensive clinical case, apart from the extensive clinical case taking, and how extensive clinical examination he used to do. So we have to follow that thing. So a detailed history and a careful inspection, and then palpation, that we have to do. We have to look for some clinical keys, like some inspection. We may get the redness or congestion, severe congestion in the affected limb usually. And obviously calf muscle becomes very much congested, and we may get this phlegmatia cerulea dolens, that is because of enormous of venous congestion, because mostly if the iliac vein or the femoral vein have been obstructed, In that case, the whole limb may become, entirely congested, and obviously sometimes there may be erythematous changes, or sometimes maybe patient will come with venous congestion and this bluish discoloration, we say the phlegmatia cerulea dolens. And sometimes because of this huge amount of congestion, it may sometimes press the arterial supply or jeopardize the arterial supply. In that case, the leg may become pale, which we say the phlegmatia alba dolens. So both these things we might get. And obviously, local warmth, the temperature will be increased. Pitting edema should be there, and tenderness on cuff compression, that is very, very important, which we say the Moses sign. This particular Moses sign may be there, that is a tenderness on cuff compression. And there's a leg circumference measurement that we may do. We sometimes we have to do that thing. And obviously there is a we say there's this Hoffman, or sorry, Homan sign, which is known as the calf pain on dorsiflexion of foot and with the knee bend. But always remember, very often the patient is completely asymptomatic on onset. Sometimes there is no symptomatology, but patient usually come with features of this, this congestion of leg or lower extremities mostly. Now, two laboratorial investigations, which is, I think, the most reliable one, which or non-invasive one that we can do is Doppler ultrasonography for veins of lower limbs or the limb which has been affected, is the most cost-effective and non-invasive diagnostic tool apart from any other thing. Because if you go for a any other invasive investigation, there are so many invasive investigation that we do, but it is perhaps most cost effective and it's very easily available, and that is why. And second thing is that increased serum D dimer level, which has to be more than 500 nanogram per ml. That has to be, if these things are there, we can think of this deep vein thrombosis. Since as I have already told that sometimes there is no, clear-cut features of deep vein thrombosis. So there is a Wales DVT scoring system. This Wales DVT scoring system is sometimes very helpful. And this scoring system, actually, we see if the score is less than 0 or to 0 is low risk, 1 to 2 is moderate risk, and if it is more than 3, it's high risk. It's actually come from the history and the clinical findings and the other alternate diagnosis. So this scoring system is available. So I'm not going in details about this scoring system, but this scoring system is a very handy tool for diagnosis of for DVT, while we have a hunch of that a patient may suffering from deep vein thrombosis from his symptomatology, from his clinical presentation, and from our clinical examination. If we get that thing, we can easily use this Wales DVT scoring system. Now, diagnostic algorithm is like that. If there is any symptomatology of DVT, and obviously if there is a probability, and if we get a D dimer positive, and then we have to, if if the scoring system is like this thing, if it is 2 or more than 2 or more than 3, so obviously it's a very high risk. So there we can go for this thing. We can first we can go for the D dimer estimation. Obviously, D dimer estimation, if it is positive, then obviously we can go for this Doppler ultrasonography. And with the Doppler ultrasonography, if it is positive, obviously DVT is there. But if the Doppler ultrasonography is negative, we can go for a D dimer. If D dimer, that means if a D dimer is positive and the ultrasonography is found negative, we can repeat the ultrasonography after 1 week, and that will give us a diagnosis. So now I'll come to the case next. Now there are two cases particularly I have shown here. I have taken 2 cases. Now the first case here, in this case, the patient has so many comorbid condition or so many favorable condition which may develop DVT, and obviously the very nice presentation. It was a case in which I actually treated in 2015. So Mr. KKB, he was 65 years of aged male patient, and he was a retired non-teaching male staff from a university. And he was about 5 feet 8 inches tall and weighing about 87 kgs. But obviously from this height and weight, you can measure the BMI, obviously. And obviously it is a stout muscular body, and he had been suffering from atopic dermatitis for last 15 years. and with lichenification that you can see from the picture on the right hand side. And there was a patient, he was a person who was suffering from COPD, and he had a history of smoking, a habit of smoking or addiction of smoking, and there was systemic hypertension for about 20 years, and also he was suffering from chronic kidney disease for last 3 years, for which he used to take allopathic medicine. For all these things, he used to take allopathic medication. Now, he was a moderate cigarette smoker, as I have already told. He had presented with severe cellulitis in left lower limb and below the knee joint, and more prominent around and below the left ankle, causing a great throbbing pain, tenderness, and tight calf muscle was there from the very beginning. Now, high fever and with tender, palpable left inguinal lymph node, and he was unable to flex the knee joint. So from the very beginning, these two things was there: the calf muscle tenderness and calf muscle pain, and the patient was unable to flex his left knee joint. Now he was advised for surgery because of this thing. He had his the allopathic physician. He actually suggested for surgery, but he opted for homeopathy because there is a family history of one of his cousin brother. He had a history of this thing, pulmonary thromboembolism, and he had a history of DVT, and from DVT he actually suffered from pulmonary thromboembolism. But he, because of his health and every issues, he actually somehow first opted for homeopathy, and he came to us for treatment. So it was a day 1 on 8/8/2020, 2015. So erythematous skin on left foot, ankle, and part of the calf muscle. There was throbbing sensation, tender, palpable, and discrete left inguinal lymph node. And there was a pyrexia of 101 degree Fahrenheit with throbbing headache was there. So belladonna 6C was given, 6 doses at an interval of 4 hours, followed by placebo. And all these drugs which has been given following the guidelines of the section 247 of Organon of Medicine, 6th edition. Okay, so somewhat altered the potency, and it was given in the liquid. The drug, one drop of drug was added with the distilled water, and in this way it was given. Now, the on day 3, it's 10/8/2015. Pyrexia continues with hot sweat, but without touching the baseline, and there was relative tachycardia. Erythema was there in the calf muscle, tenderness, edema, unable to flex left knee joint. All were present, and obviously this pyrexia and this there was relative tachycardia, and because of this thing, pyrogen 200 dose was given, followed by placebo. And he was advised for Doppler ultrasonography of the affected limb to exclude the possibilities of DVT because of his history and all these factors. So it was on day 3. On day 4, the inguinal lymph node had actually subsided, fever subsided. Now calf muscle edema actually decreased. Now burning, stinging pain in affected limb started with low urine output, and there was an loss of thirst. So from the burning, stinging pain with low urine output and loss of thirst, and as he was suffering from CKD also, so because of the symptomatology, we actually gave this Apis mellifica 200C 2 doses at 12 hours interval. And on day 5, this Doppler ultrasonography report actually came, where it was showing that deep venous thrombosis involving popliteal and posterior tibial vein. So popliteal and posterior tibial vein, that means the distal part of DVT. So on day 6, after the Apis mellifica was given on 13/8/2015, stinging pain was gone, and edema and other inflammatory features, those who were present, it was reduced than before. Inguinal lymph node was no more palpable. So since there was improvement, obviously we gave him placebo. Now, again on the day 8, severe throbbing and bursting sensation returned in his leg, better by elevating the limb. So he was elevating the limb. So obviously from the symptomatology, this particular thing, and as because it was from obviously venous inflammation was there, thrombophlebitis. So Viperat-Trova 200C 2 doses was given, but once daily for 2 consecutive days. Now on day 11, now atrocious burning and markedly aggravated at night while going to sleep. This symptom actually came with much psychological restlessness. Patient becomes extremely restless, and obviously this throbbing sensation which was there on hanging the leg down and elevating the leg, actually giving relief, that actually gone. But this particular symptom actually came, the atrocious burning with marked aggravation at night while going to sleep, and relief of this burning pain while applying the cold water. And this psychological restlessness was extreme. So depending on that thing, Lachesis 200C, 3 doses was given. One globule number 10 in 15 ml of distilled water, divided into 3 doses, once daily at morning after 10 times succussion. This way it was given to somewhat alter the potency. So it was on day 11. And then on day 14, we found that burning sensation was much relieved, no cuff muscle tenderness and edema was there, and patient was quite peaceful because there was improvement at the end, and that you can also see from the picture itself. So we gave him placebo. Now, on day 19, we found the limb is almost normal. He was able to, he could walk freely and can flex his left knee joint properly without having any trouble. So placebo was again given, and he was advised for repeat Doppler USG of the affected limb. Now, repeat Doppler USG was done by day 33. Repeat Doppler USG was done, and this Doppler USG shows that normal venous Doppler study. There was no this thing. So no medicine was given. And again, as we told that within 10 years it may come back. So the patient continued to be in a good condition of limb since then, and for next 7 years he was followed. Actually, he was advised to contact us during this course of time. If any problem, actually, he was advised that if any such problem recurs, then we have to again intervene. We may require to intervene once again, but luckily that did not reappear, because after the completion of that thing, we actually do an entire case taking. We gave him the indicated drug, which was obviously sulfur. We actually used sulfur, and after giving sulfur, his skin symptomatology and everything actually reduced somewhat. And because after that he did not require any kind of he used to take all these antihypertensive drug, and obviously he used to take the treatment for CKD. All these things were going, but and despite of that thing, we actually gave our drug, and he didn't suffer from DVT anymore in next 7 years since we had in touch with him. So this was the first case, and the second, this particular case was actually reported. This was a case report in the Journal of Ayurveda Integrated Medicine, and it was obviously PubMed journal, index journal, so it was there. So, and the second case, now this second case is again, this man is a retired person, and he used to work in with WBAC-DCL, West Bengal State Electricity Board. So, and he used to live alone, and he used to live in a fourth floor of a building which doesn't have a lift. So it was a problem for him to come down. And so he actually contacted initially, and this person is known to one of my student. So he actually contacted initially over telephone, and he was asked to give us the photograph, and then we actually went over there. Is one of my students' relative, as I told you. So on the day one, it is on 23rd 9 2023, we found this kind of ulceration was over there. It was having pain and obviously redness, and there was a history of Europe tour. He actually came back from Europe tour, and then he suffered from fever, and he was there in bed, and he gradually developed this kind of leg lower limb pain, and after that there was a formation of like blisters like this thing, and then this ulcer actually formed. And on the day one, when we went over there, we found this kind of ulceration. And there's obviously, we can see the redness or erythematous changes over there, and obviously the pedal edema that you can see in this particular patient. And obviously that you can also see in the right lower limb. Obviously, this is the right lower limb, And if you look at the foot, you can see this blackish coloration. That is because of stasis pigmentation. As because he has also a history of this varicose vein, early varicosity. Now, and he used to stand for a quite long time because of his job. Now, the blood report which actually came, actually he since there was no lift, so it was not possible for him to come down and obviously go for a ultrasonography. What we suggested to do the D dimer estimation if it is possible, because there are the people may come to your place and they can collect your blood, and obviously you can have that facility, but you cannot have this ultrasonography over here. So uh, so the blood test was done, and in case of blood test, you can see here uh, the D dimer which I have mentioned, which I have shown over here, was 1929 nanogram FU per ml, and that is one on 27th September. Okay. And there was no the pass was given for this for pass culture, but there was nothing else in this pass culture. So, and the hemoglobin percentage was 12.5, and other parameters that you can see. So this was on day 5. He was advised for blood test and it was given, and obviously the next day he gave the blood, and the report came to us on day 5. So it was his this D dimer level. Now, Wells criteria was there, and from the Wells criteria, you can see the criteria. If we look at the criteria, the result is +3. Okay, so +3 or more, that means there is a high risk of development of deep vein thrombosis. So from the Wales score and from the D dimer estimation, we actually thought this was a case of obviously possible case of DVT. That's why we have written, since we didn't have that kind of USG or Doppler USG with us. So this is a possible case of DVT. We have named it. So from the symptomatology, all the symptomatology actually came in this particular case. What we do, we do the entire case taking. And from the case taking, it came the patient was entirely, it was a case of pulsatilla. So he was given pulsatilla in 0/1, uh, one globule number 10 in 100 ml of distilled water with 10 drops of RS. We divided into 14 doses, and then we asked him to give 10 times succussion and add 1 dose of that particular medicine with half cup of distilled water, stir it well, and take 1 teaspoonful from this cup in this way twice daily. Okay, so it was then after one was over, 2 to 3 days gap, then Pulsatilla 0/2. So like this we continued. And on day 14, you can see the D dimer is now less. It was initially 1929. Now it has come down to 1514. Okay, it was on, and then next it is on day 13, that is on 5th of October. And then day 16, see the changes that is actually coming on day 16th and day 18th, that you can see the changes. The redness has reduced, the swelling has reduced, the ulcerations which was there, they have also reduced, and they are now healing properly. On now on day 18, since now he was able to move, because initially he was not able to move properly because there was a no pain in his limb, and for him to come down through staircase and go for this kind of ultrasonography. Now it was possible for him, so he went for this ultrasonography. So DVT, we expected DVT, so that's why we asked for the Doppler ultrasonography of the affected limb veins. So what we got, no evidence of deep vein thrombosis in either of the lower limbs. Both limbs were advised, but obviously improvement was there thereafter he did that thing. So maybe it was there, it was gone, and we are getting this thing. Bilateral saphenofemoral junction are competent. Few incompetent perforator veins are seen in the bilateral lower limbs as described in this, I have marked with red, and diffuse circumferential substantial edema and cellulitis changes in the right cuff. Now there is one study which was published in the Eurasian Journal of Medicine in 2018, which actually says, where it has been shown, or where it has been found, that incompetent perforator veins was observed in 50.91% of patients with chronic deep vein thrombosis. So those who have incompetent perforator vein, they have a chance of development of DVT, obviously, in case of in this case. So he might have. We are not claiming, we are not making any tall claim that he had DVT, obviously, but obviously likely to have DVT because the Wales score was 3, and obviously D dimer was very, very high. Okay. Now, on day 32, that we can see again pulsatilla 0/3, 0/4, like this it was going. And see, we can see the changes on day 39th. We can see the changes. See the entirely the edema is gone, the erythema is gone, and obviously there is no swelling, and obviously the ulcers which was there, now they are in almost at the verge of complete healing. And this was on day 46. And then again he was advised for this D dimer estimation. So actually D dimer actually helps us to know whether there is any kind of venous thrombus formation in the vein. So now see the D dimer quantitative value. Initially it was also quantitative value, so quantitative value is 0.60. So obviously it is well within the normal level. Okay, so now this particular case is, I think, it was the dimer is okay. The Doppler USD shows there was no deep vein thrombosis at that time when he did that thing, and obviously patient got cured. So the conclusion is that, my conclusion from what we have done over here, that homeopathy can play a significant therapeutic role in a very serious clinical conditions like DVT. Now, provided the drugs are needed to be carefully selected on the basis of the individualization of the case. I have shown here two cases. One case where we have individualized the entire case from the very beginning, and we go with the constitutional drug in a 50 millisimolar potency. And the prior one, first one, as the symptomatology came, we go in that way. But then again, what we can conclude from the first case is that when we are giving the acute drugs or not so deep drug, the symptomatology was hopping, changing, and as the symptomatology was changing, we are changing our drug. But when the constitutional symptom flared up, it was lachesis. Obviously, psychological symptom was extremely important over there, and obviously the general modality. So since we give the lachesis, the case completely cured and completely recovered, or completely cured, rather, we can say, in a very short span of time. So constitutional drug and individualization is extremely important, and the totality of the symptom and the personalized data. These things are extremely important for the selection of medicine. And consideration of the pathogenicity level and the proper diagnosis of the disease is again extremely important for the selection of your medicine, your potency, your then again reputation, and obviously what may be the outcome of the in your case, that we have to assess. So, and homeopathy may also be safely used in patient with other conventional drug. So in these cases, the first case, we can see the patient was taking the treatment for CKD. He had medication for his atopic allergic dermatitis and lichenification. He was suffering from hypertension. He used to take drug for that thing. Obviously, we do not have the have the what we can say, uh, the fancy to remove all those drugs which these people are taking. So we have to keep all those drugs, and then again we have to give our drug depending on the available totality of the symptom. Now, more such case reports when published would make a strong base of evidence, because most of the homeopath people, our homeopath doctors, as I say, are very, very simple. They're very simple person, and they remains very happy if their patient is cured. But they are happy with the very small thing. But if they develop this kind of habit of documenting the cases that they are curing, that will create an entire pool. See, the thing is that it's not like that the double blind placebo control trial, or meta-analysis. What we have to do, we have to generate bulk of such evidence-based cases, or evidence-based cured cases. So obviously that will obviously create the foundation of our system, because Tomorrow somebody may ask whether you have this kind of treatment or whether you have the scope of treating such diseases. So we can say yes, we have, because in case of, in medical world, now we depend on the documentation. So more such case reports when published would make a strong base of evidence of efficacy of homeopathic treatment in such conditions. So thank you very much for giving me the opportunity to present my case in this nice platform. And with these words, I will conclude my saying that Om Sarve Bhavantu Sukhinah, Sarve Santu Niramayaha, Sarve Bhadrani Pashyantu, Ma Kaschi Dukhu Bhagu Bhavet, Om Shanti Shanti Shanti. So thank you, sir.
Saptarishi sir, it's really a wonderful session indeed. You beautifully presented the session throughout your presentation. What we noted was that the fluency of your knowledge in this area, and the two cases shown in the platform was really brilliant. And this is what we have to be, as you rightly point out, that all of us need to publish these things, and then only public will aware about all those things. These are the things that homeopathy can do. Uh, that's the beauty of the presentation. Congratulations, and hope we will have some more case presentation in the future, so that we are, since we are uploading all these things on the very next day itself, people can watch and share with the public also. Then that's what the purpose of this International Forum for Promoting, to promote homeopathy among public. And that's really very good to have this kind of presentation. Congrats once again. And those who want to participate in the discussion may raise your hand or can come forward, so that we will allow you to speak to Saptarishi sir. Yes. Sir, what's your success case in this kind of post-surgical cases that are coming in the way? Whether you treat in a as a we know that a lot of people are undergoing surgical cases, surgeries for these things, and then thereafter, even after surgery, they are getting this kind of diseases again, and then they may opt to homeopathy also.
I'm not getting your question, sir. Once again,
What's your success rate in those post-surgical conditions which are recurring?
post-surgical condition, in case of surgery, there is no chance of occurrence of anymore, because you are cutting out until unless you are doing any kind of otomy. If it is the ectomy, then obviously there is no chance of recurrence of all such things. But what I will rather suggest here, that yes, we have evidence like that. I'll say that in case of nephrolithiasis, you can get a chance. We have a good amount of data, and we have good amount of documentation that in case of nephrolithiasis, yes, we can cure our patient. We can remove those stones, but not the staghorn calculus or the mulberry stone. Please do not try to remove that staghorn calculi, or if the stone is very large. Obviously, you have to take a time frame. Because if you here, then again, obviously there is a chance of development of complications like hydronephrosis, and obviously patient may lose his kidney. So be very aware, be very judgmental from the very beginning, whether you can take the case. And actually that knowledge comes from the study of surgery. Like, I'll say that in case of cholelithiasis, yes, I do not take chance. Obviously, I have seen patient in whom in case of cholelithiasis, in case of my father, actually we thought that we will go for an interval cholecystectomy, because he was admitted in the nursing home with some other condition. And because of that thing, we thought that we will go for a interval cholecystectomy. But meanwhile, he had developed his abdominal pain, so I gave our medication with the symptom similarity. What happens, actually, the cholelithiasis is passed on, but it actually created the acute pancreatitis. So I'll ask my fraternity that in such cases, please do not try that thing. It is better to go for a cholecystectomy in case of elderly patient. But in case of children, in case of young child, in case of cholelithiasis, we may try, obviously, because in a very young age, tender age, if the cholecystectomy is done, obviously there's a lot of complications, in rest of his life. But again, the time should be, it should be a very time bound thing. If I always, what we do in our hospital, we say, give us 3 months, 3 months, 6 months time we take, if it is possible. Then either in first 3 months, if we are seeing any kind of changes, then we keep for another 3 months. And if we are getting a success, then only we continue. Otherwise, we just simply refer this case. We do not have the privilege to keep the cases for a number of time, or prolonged time, because we, actually, we say it's a very even a less than 1% of cases of cholelithiasis turn into gallbladder carcinoma. But I have seen patients in whom the patients were treated, the patient were treated with homeopath doctors, in the hands of homeopath doctors, and they have developed gallbladder carcinoma later on. And the life is very valuable. So life is extremely valuable. So, and we do not have any right to, do any such thing, any such blunder. So it is from the very beginning, we say that in case of surgery. But anorectal diseases, we have obviously those surgical diseases like fistula in ano. In case of anal fissure, we have a very good amount of
Yes,
scope. We
yes,
treat
sir.
such cases over there. But obviously, in case of pyloric stenosis, we do not have the any scope. In case of gastric ulcer, in case of duodenal ulcer, obviously we have scope.
Yes, sir. Yes,
So
sir. Now,
pancreatitis also we have cause, but in case of pancreatic, if
yes,
there is
sir,
a
there
pancreatic
are limitations,
a
sir.
calculi is there, then obviously we do not do take such cases, because obviously it may damage the beta cells again because of the retrograde pressure. So obviously we
Okay.
ask to go for surgery for
Okay.
MRCP or like that thing.
Okay, sir. Okay, sir. Now I invite Dr. Maria Salceda to say a vote of thanks, because just a few minutes remaining only. Dr. Maria Salceda, please say a vote of thanks to the session. You can make the comments also here.
Thanks, Dr. Danesh. Good morning, good evening to all of you. Thanks, Dr. SAPTARSHI. It was an amazing presentation, an amazing conference. And thanks for showing us the great effect that we have with homeopathy in this kind of cases. This is the magical of homeopathy, that you can cure from the internal and not just putting some external things. So you are healing all the body, all the bodies that we have, all the subtle bodies, and all, of course, our physical body. So thank you very much for a great conference, and I enjoy a lot all the clinical issues that you take it in account at the moment when you saw a patient. So thanks for all your very, very nice conference. Thank you very much. Congratulations.
Thank you very much.
Thanks,
Thank you
Dr.
very much.
Danishi.
Thank you.
Thank you, Dr. Maria Salceda, and those who participate in the session. Thank you once again to Dr. SAPTARSHI Chaudhary sir for an excellent session in this evening. Hope we can have some more presentation in the future. And tomorrow we will have a session from Dr. Balachandran, and Doctor will be talking about the importance of biochemic medicine in practice, part 2. With that, we come to the end of the day, 1481. Thank you.
Thank you. Thank you. Good night.
It's over to Dr. Maria. It's Shaila to moderate the Malayalam session now.